why did the birth plan attend yoga classes?
That's a really good question. Why?
You're too intrigued.
I am. I'm really excited, actually.
To stay flexible for the big day. Oh, you like it. I like it.
This is Stirrups, Candid Conversations in Women's Health, the podcast where we answer your burning questions and discuss the evolution of women's health through every stage of life. Join Dr. Randolph Scott and duly certified women's health nurse practitioner and certified nurse midwife, Kerry Autry, as they discuss the unique health concerns women face and share expert advice to assist you on your journey to maintaining your health and wellness. If you're looking for informative discussions, tips from qualified professionals, and a community dedicated to women's well-being, then you're in the right place.
So silly, but so true.
Yeah, but you must be flexible, right?
That's the thing. Like I almost don't love the word birth plan because it really should be about flexibility.
Yep.
Yeah.
So let's start this off. Birth plans, they are a dime a dozen. You'll see them. But sometimes trying to figure out what's right for you can be a little bit more challenging. And so from what you've seen, Kerry, and particularly your expertise as a midwife, we always have, how are we planning for this one final big day? I mean, it's been 9 months and everybody is excited,
Also terrified.
It's a little bit of both.
Yeah.
And I think, over the years and experience, I've seen a whole lot for that big day. I have seen tailgating. Have you seen that?
No, but that's my favorite.
Oh, that's the
way to go.
Yeah, that's the way to do it. I've seen tailgating.
Keeping a little bit of a minimum for that poor mom.
Yeah, exactly. Trying to bring it down, but certainly celebrate the big day that's coming up. Is some challenges along the way, and I think the power of the birth plan is a good one in the sense that it's empowering to know what your wishes are and to really see if you can exercise those wishes during the course of this particular day and event for you. And so
I think it's almost, my favorite thing about a birth plan is more that it sort of puts in front of, parents, what are the choices that I might be asked to make? And what are my possible answers to that? Because for so many people, there's a lot in a birth plan that you're going to look at and be like, yeah, I never even considered that. Like, I have to make a choice about that?
Yeah.
And the answer is no, you don't have to make a choice about it. But just being aware that those choices exist and considering what might be some things that are important to you and what things are maybe not as important, where you have flexibility, where you can bend.
Yeah. We have preferences, and that's what the birth plan is really about. What are your personal preferences about this particular experience, and how do I express that to the staff and to the providers? I think they're great. They give you a voice in a certain extent. Now, if you don't have a birth plan at all, that's okay too. You will have a baby. I promise you that. That is guaranteed. But if you do, it kind of is reassuring at the same time. So starting off with the aspect of labor. And so for us, some patients are planning for a C-section. Mm-hmm. And that's okay if that's where you are. We have C-sections that are scheduled that are elective because, hey, that's your personal choice and that's what you want to have done. And you can exercise that freedom with your provider who's choosing to do the C-section for you. And it's not an unusual request for that to actually happen. But really what we're focused on is here in the birth plan that we're discussing is the patient who is considering the vaginal delivery.
At least planning for that, yep.
Or planning for that.
Yep.
Yes, that's correct. And so when we talk about birth plans, some patients have to have an induction. And what does that induction look like, and how is that induction performed? And what are some of the ways you have seen that inductions are performed?
Well, the way the inductions go, they really do tend to they tend to be really specific to the patient because there are so many parts of patient history and, where the patient is in that process that are going to affect what happens with an induction. But the point of the induction is that for whatever reason, this person really needs to be in labor now. So the goal of the induction is to get labor started. And there's a couple of tools that we use. There's really kind of 3 primary ones that we go to. If patients are not dilated enough, the first part of the induction is usually aimed at getting them at least 3 to 4 centimeters. That looks like a couple of different things, sometimes medicine, sometimes a bit more mechanical. People have heard, talking about a balloon. That's a bit more of a mechanical way to start to open that uterus. Sometimes we get lucky and that's enough to get labor rolling. And sometimes we have to kind of go to our next tools.
Yeah. And, from the induction standpoint, the balloon is a great and very useful tool.
Yep.
It is mechanical. There's no medicine attached to the balloon.
No.
The balloon goes inside the uterus and not the bladder.
Yeah.
It helps dilate a patient in a way that after it's placed, there's a certain level of comfort that you have, even to the point where you might even be able to get some rest and some sleep.
Yeah.
Yeah.
That was always my favorite.
Yeah. So if it can work.
Go to sleep.
Yeah. Go to sleep.
Just go to sleep.
And try to get it while you can. Because, sleep will be a premium for probably quite some time. So the balloon is a great way. The next step for us is oftentimes medication that helps you to contract. And a lot of patients are very aware of that and have that as an option. But Pitocin is that medicine that really helps stimulate the aspect of the contractions and helps promote that labor experience. Now, we can talk a lot about the Pitocin, what it does, and potential side effects and things like that. But it's one of those very useful methods that can get things going. What's that?
I think it's got a terrible, terrible rep out there. Like when you say the word Pitocin, you can almost see everyone in the room, even if they've never had a baby, you still see everyone in the room
Cringe.
go,
Yeah.
And I get it. I get it. But what's really important for people to understand is we're only ever going to use enough Pitocin to get your body to do what we're asking it to do.
That's right.
We only need your body to understand that we're asking it to start contracting. We need it to go into labor. So we start it really low and we only increase it until your body has figured out what we're asking it to do. Once we get there, once your body has started to contract in a pattern that makes sense, nobody's going to keep pushing it up. We're where we need to be. So we start it low, we go up slowly, and we only use as much as we need to.
That is a fantastic response to Pitocin overall. But I see that there's a certain level of fear because they're like, are my contractions going to be stronger? Well, that may be a possibility. We're here to have a baby. Yeah. And so that is a consideration with respect to the Pitocin. And I try to relate to patients that Pitocin is a synthetic form of what your body produces during labor, which is oxytocin. Yeah. So it is a very good tool to move that pregnancy forward, particularly when you have to. Yeah. And so next steps, though, if Pitocin is not a factor for us, would be?
Well, or even if it is, sometimes if we need to just kind of continue to get things moving along, the next tool is usually that we break your water.
Yeah.
Yep.
So that's usually in conjunction with all these other things. Yeah. You may have the Foley catheter, which is that balloon that actually goes in. And then you'll have the Pitocin. And that, final thing here for us is we're talking about breaking your water to help speed up the process. And there's a couple other things I think it's worth mentioning in terms of just getting things started. There is what's called a prostaglandin or Cytotec or misoprostol as another generic name for that medication. That's also used. Oftentimes that's an alternative perhaps to the balloon, particularly when you can't get the balloon in.
I was going to say sometimes it even leads up to the balloon.
Yeah. And so, you want to have some consideration for that. And there's another one that I think is very helpful before you ever get to the hospital, while you're in your doctor's office, that can perhaps get this process started. And Kerry, you know much about that.
So people will talk about it and call it membrane stripping. It's one of the things that we use for sure. Studies have shown it's really safe after 39 weeks. So we can kind of help convince your body. Again, we're asking your body to go into labor, and it's kind of a way of asking it without putting anything into you. So it's not comfortable for a lot of patients, but it's usually relatively quick. But we try to reach through the cervix and separate the bag of water, separate the amniotic sac from the inside of the cervix, which I tell patients it just essentially irritates the heck out of the cervix. And if we get lucky, it's enough to start those contractions.
Yeah, it's not guaranteed, it's not foolproof, but it's one of the means there for us. And next line of business for us is how do you manage that pain that occurs during pregnancy? So pain management. So options there, Kerry.
There's a lot. I think everybody thinks of an epidural, and it's an incredible tool, but there's a lot that you can do before then. So, sometimes we're looking at moving. Like moving can be enough to help with pain in the earlier parts of labor. If you're kind of moving through those contractions, whether you're walking or, holding on to something and just kind of squatting and rocking into those contractions. I really love a shower. I think that's a great way to labor because you've got that warm water hitting your back. You've got the sound of the water. And then just the heat from the water can really help with the pain. There's birthing balls. I mean, there are so many tools out there, which is, I think, like the key to this birthing plan that sometimes you don't even know what to ask for. Sure. So you get in there and you think there's nothing or there's an epidural. Yeah. Where there's a lot of other tools in between.
Yeah. And I think taking at least or having some consideration for the other methods can perhaps maybe even get you through this process where you don't need an epidural. Right. Sometimes that's a goal as well, right. Not to have an epidural. Yeah. And I think those are certainly reasonable expectations. And I always try to challenge my patients in the sense that you don't know what you're capable of, until you put to the test and see what you can do. So why not try it, see how it works? And if it doesn't,
we'll change our plan.
Then we got another.
Because we can change.
Yeah, because we're flexible, right? Because we're changing it up, right?
But then there's other tools that we can use earlier in labor that aren't necessarily an epidural. If you've got somebody who's been laboring for a long time and you can see like they're getting worn out, but we've got a ways to go, because I always remind people like labor is a marathon. Yeah. So sleeping is key. So if you're earlier on, maybe we're looking at an IV narcotic medication, which would allow you to sleep. But even more importantly, it's going to allow you to relax, which is going to allow those contractions to do the things that we need them to do. Yeah. So, earlier in labor, let's get something like that into you. Let's take a good nap, and then we'll see where we are when you wake up. Yeah.
Yeah. And I think that's a very effective method for temporary circumstance to kind of get them through.
It has to be earlier in labor. It's not an option later in labor.
Yeah, when you're getting ready to push your baby out, the IV pain medicine is probably not the best idea for you. Only in the sense that if it's through the IV, it goes to both you and to the baby. And so we want to make sure that the baby is alert and active afterwards.
Those babies to breathe.
Yeah, we need all of that going. Some of our patients are considering, the aspect of hydrotherapy, which is the equivalent of, the water birth kind of deal. And so, but not every facility is equipped to be able to help you manage in that particular way.
No, I do tell people if that's something that's really important to you, you need to find a hospital that's going to allow you to do that. And that's something you should look for before you consider almost anything else. If that's something that's that really important to you. Yeah. Because there are not a lot of hospitals out there that will do it. And there are even fewer hospitals that would allow you to actually deliver in the hospital, in the tub, which is not necessarily a bad thing, because the water is really a tool to manage the contraction pain. Right. So that's sometimes very hard to find that right combination, but it's important because oftentimes when you're choosing a practice and providers, that dictates which hospital you go to. Right. And so you want to start really top down then, meaning do the hospital have all of these choices, and then I'll find my provider. Yeah. Who's going to meet me there?
Yeah, who's going to meet me there?
And then there's the nitrous oxide that even fewer people are familiar with. I think it's a really nice tool, though, for, we all have those patients that really want a lot of control. Yeah. And they're frightened of an epidural because they have to give up a lot of control with an epidural. Sure. But with that nitrous oxide, you have the mask. You put it to your face, you breathe in when you need it, you let it go when you don't need it, and you can use that all the way through delivery.
That's right. And nitrous oxide, I think, is a great method if you want to continue with the labor aspect, have some level of mobility about what's taking place, because you only have it, or you only breathe in the aspect of the nitrous oxide or laughing gas during the time of your contractions. Outside of your contractions, then you don't necessarily need it. All right. Laboring tools. The next.
I know we talked a little bit about this before, but because they are like a great way to help get the baby in the right position. Yeah. Because it's not easy for these little babies to find their way through. They've got to turn like 5 times to get through this pelvis. Yeah. So these tools really help you get your pelvis in different positions to allow the baby to make those turns, but they're also really great for managing pain. Yeah.
And one of the fan favorites is the birthing ball. Yeah. That bounce, that rock can certainly help. I think it's a great tool even before you ever even go to the hospital.
Absolutely.
And sometimes that rocking, that stimulation can perhaps promote some labor aspect of things for you. And so, and I know you've seen some other things there too. Yeah.
Peanut ball. The nurses love the peanut balls. They're always going to suggest those, but they're a nice way to kind of relax and keep the pelvis open and, kind of turn and move and get the pelvis in different angles that really help. And of course, the squatting bars, those are always fantastic too.
Yeah, the squatting bars.
Those are ones you have to ask for. The nurses don't always volunteer those.
Those are sometimes a little bit trickier with the squat bar, but certainly it's a tool that's available in most labor and deliveries. And the peanut ball, as you were mentioning, that's one of my favorites, in terms of getting that baby to rotate in the position to allow it to continue what we call descension or coming down the pelvis, particularly if the doctor is examining the patient and they think the baby's off just a little bit. And this is a game of not inches, it's really centimeters. And so we're always talking about, how many centimeters are you dilated? And so 1 centimeter can make a huge difference in that regard.
I was going to say, I don't know if it's mentioned later, but one of my other favorite laboring tools, and people will always look at me like I'm crazy, but for first-time moms, it's huge. A mirror. Yes. I know, because they always look at you like you're crazy. But if they are willing to consider a mirror, because one of the biggest challenges for first-time moms is, I talk to people, like, here's the problem. You're going to go into this hospital. They're going to shine like 800 spotlights on your vagina. There's going to feel like there's 200 people in the room. And then they're going to say, we just want you to use the muscles that you use to poop. Yeah. Let me just tell you how much you're going to want to do that. Like not at all. Yeah. And it's really hard to find the muscles that you need to engage. But when I could convince a patient to try the mirror, when they would have that visual feedback, when they'd use the right muscles and they would see that head rock forward. Yeah. It really got and it gave you the feedback, like, those are the muscles. Like, those are the ones that I needed to use. All those other times I was pushing and nothing was happening. But I was using every bit of might I had.
And it was going nowhere.
It was going nowhere.
But you saw it through the mirror.
But when you see that head rock, you're like, okay, now I know what I need to do.
Oh, there is, as a physician helping a mom to deliver, when we see moms
and you
get
see
it, when you get it's like everybody's getting pumped up. Yes, that's it.
That's it.
You got to do it. Yeah, more of that, more. Yeah. So it's exciting for everybody once you can see that. But I think the mirror is a far unutilized tool that I think is fantastic.
I agree.
When you're pushing that baby down the
that's
canal.
really for the last.
Yeah, that's
part.
the last. That's the last ditch effort for you. Okay. Delivery room atmosphere, creating that ambiance. How can you do that?
It's harder to do in the hospital, but it can be done. For much of labor, it's going to be you, your partner, and a nurse will be in and out. But for a lot of labor, you'll be in the room on your own. So you can have the lights dimmed. You can have music. You can have, think about the things that are important to you. I'm trying to think of the things that people always forget. Chapstick is always the one that comes to mind. Chapstick is huge.
It is.
These women are like breathing through their mouths over and over for hours, and hospitals are dry. Like, I always tell my dads, I'm like, you have 2 jobs between contractions: apply chapstick and give her water.
Yeah, that's it. And a massage. That's it.
That's right.
That's your job.
No, that's not really the same thing. But you do have some ability to really kind of tailor that space to make it your own, because you will be there for a while.
That's right. And, it's the marathon that you're speaking about. It takes a long time, some shorter than others, obviously, for that baby to come down. But especially for first-time moms, you want to really take in things that would make you comfortable during your experience. And sometimes that's just dim lights. That's your own playlist. Sometimes there's
something empowering.
Yeah.
And pumpy.
Yeah. Something, from aromatherapy, smell goods, and things like that.
I really love aromatherapy rollers. So if that's something that if essential oils work really well for you, and sometimes hospitals have policies that they don't want you to use aromatherapy throughout the room, but you can use something like a roller that you would apply to your template behind the ear. Peppermint is really good.
Yes.
Lavender is really good. And those, they're easily available, but you can also make your own if you want to try and come up with a really tailored scent.
And something that comes to mind when we're talking about the delivery room is, who do you want there? I mean,
big question.
That's a huge question,
because
some of it is not even up to you. Some of it is made for you in that sense. And so you want to know from a hospital sense, we were going back to that hospital, how many people can be in the room?
Right.
Does that include that or not? Would that include a doula? And that's another factor for us. And so some hospitals, sometimes the policy is just 2 people. And guess who's included in that one? Daddy-o. And so...
It's kind of a little crazy since COVID.
Yeah.
Before COVID, it was like entire parties.
Yeah. Now it's like 2 people.
I know.
Yeah, and one of which is that.
But, I would say before COVID, when there were huge groups of people, I don't know about you, but it felt a little chaotic at times.
It did.
And not that COVID was hard, but having to kind of make that a more intimate experience, I think has been really helpful for some people. And for some people, I think it's even been nice to be able to say to the entire extended family, ooh sorry, the hospital said no.
Not my policy.
Or I tell them to use me all the time. I'm like, make me the bad guy. Tell them that your midwife said no.
Yeah. And sometimes, when you say 2 people and you include dad, well, whose mom? Is it my mom? His mom?
Exactly.
Now.
And I'm like, a doula is good.
Yeah.
Then you don't have to even choose.
Is that right? So you want to know that kind of information in terms of considerations for the atmosphere.
And sometimes when you're considering who's going to be in the room, there's really 2 different times that you have to think about. Like who's going to be there for the labor, which is a long part of time. And maybe that's a separate group of people than you want there for the pushing stage, which is when you're much more exposed.
Yeah.
So
and that's
maybe,
a different kind of circumstance, right?
Maybe you have people that you just tell up front, I want you there for labor, but I really would like you to excuse yourself when we get to that part of the labor.
And that's okay too. And sometimes,
and then please come on back after.
Yeah. Yes, that's what I'm saying. Yeah. Sometimes it's like a tag team, meaning, okay, both moms want to be there. How about we alternate? You take this shift, I take this shift, and we work it in that kind of fashion. But the
hospitals have space for families that's outside of the labor room.
That's right. And so there's usually places to go and things like that.
They usually have microwaves and snacks.
Right. Yeah. Right. And so to that extent,
you can just move the tailgate down there.
Oh yeah, that's right. We still talk about the tailgate. That's right. The one factor in terms of atmosphere, we talked about this a little bit before about what you can eat. Can you eat? Can you eat while you're in labor?
Not usually.
Yeah, I know. That's a bummer.
I know. And it's one of the reasons I encourage patients to use whatever tools they have at their disposal, whether it's their providers in office, whether it's a doula, whether it's a birth plan, whether it's just a labor support person, to labor at home as long as it's safe to do that. Because then you can have snacks, you can have liquids, you can be in your own space, which is sometimes really empowering for people. Now, of course, there's going to come a point where you're going to have to go in, and that's going to be the safest place for you. But until then, because they're not going to let you eat anything.
Yeah, that's right. And now
they've got lots and lots of soup, though.
Popsicles,
soups,
popsicles.
Soda.
You get treated to those all day.
All the apple juice you can drink,
right,
and then some.
And speaking of which, how do you feel about dads eating? Should they be?
They should eat, and they really should. Yeah. They don't need to have a 4-course meal, but they need to keep up their nutritional intake as well, because it's a marathon for them as well.
Sure. And I just say, not in the room. Okay. So if you do so, meet that challenge someplace else. Don't come in with the burgers and fries.
Right, definitely.
Wouldn't be a good idea. Okay. Fetal monitoring is the next thing that we talk about often with birth plans.
So usually there's two big choices, but sometimes the choice really isn't yours. I think most people would prefer intermittent monitoring, which means the nurse will come in and put the monitors on the baby for a certain amount of time, watch the baby, and if everything looks good, they'll actually take you off the monitors and allow you to move around in the time in between.
Yeah.
But there's some medical considerations that would make that just not a good option for a lot of people. Yeah. Otherwise, they have the continuous monitoring.
Yeah, the continuous is always going. But most modern hospitals now have it where it's wireless.
Exactly.
And so that's good. So you're still able to dance around the room and have great monitoring of the baby all at the same time. Now, wireless monitoring, it is technology. Sometimes there are some technical things where it doesn't necessarily work well.
The nurses will come in and adjust it often.
And a lot.
But they will do it. And they will do it gladly because they know it's important. It's actually important to move through labor. So
correct. And so how about photography and videography? What do you think?
It's personal, but also you need to be familiar with our hospital policies because a lot of times there are some limitations by the hospital about when you can and can't take pictures or videos.
Right.
But it's something really to think about if you really would like those videos later. Some people, they're really meaningful and some people, they're really uncomfortable. But those are definitely boundaries I'd set ahead of time.
And so I would find out again what the hospital policy would be for videotaping. Most hospitals do not allow the aspect of video during the delivery. Yeah. Now, as the baby is coming out. Prior to that time, it's very reasonable to record.
After?
Yeah, and even after. Immediately after this baby is out and doing well, then I don't think there's any reason not to capture that moment and that experience if that's something that you choose to do.
Of course. The next thing on this birth plan model that we're looking at is a question about medical students. And sometimes that's a choice you have and sometimes it's not.
Right.
But if it's something that really you just can't even stand the thought of it, it's a good thing to put out there at the beginning of your labor that it's not something you're comfortable with. And hospitals will respect your choices if you say, please no. Yeah,
that's not where I want to be at this point. And so so that's certainly understood. Sometimes I think the best circumstance is for you to understand which hospitals do have medical students and not. And so you can make an informed decision about that.
It is one of those things that you might consider when you're picking a hospital.
Correct. Yeah. And then the other aspect of it is that I think, from a staffing, nursing aspect, if there's some level of introduction that takes place, rather than just bulldozing your way through, being respectful of what this experience could mean for that patient.
Well, I mean, it's hard to say because it's hard to paint them all with the same brush because, people who are drawn to this work is not easy work. Yeah. It is long, it's demanding. Usually students are very passionate. Like if they want to be there, they can be an incredible resource.
I was a student once.
And I'm very grateful to all the moms that allowed me to be there.
Thank you very much. I appreciate you. All the women. Yes. And so they can be both helpful for you and help you through that experience all at the same time. I think they're great.
Sometimes they have to stick around more. Yeah. So sometimes it's a really nice experience because they're in that process of learning what labor looks like. So they spend more time with you. They are eager to use all the things that they've been taught.
Right,
So sometimes it's actually a really beautiful experience.
As a matter of fact, I can tell you that some of the patients when I was a student come back was like, you were the best part of the experience.
Exactly.
So it can be helpful for you. So it's one of those things, just kind of be flexible is the key factor here for us. Next item of business for us is delivery. Position.
Right. So I mean, it's so hard because there's definitely a lot of pressure to deliver in one position, but you can labor in a lot of positions, certainly, but you can really deliver in a lot of positions too.
That's correct.
Depending on, and it's so personalized too, because sometimes depending on where the baby is, sometimes there's other positions that really are more effective.
Right.
I think we're all more familiar with women being on their back with their feet in stirrups, but there are a lot of other options.
There's some other options, and a lot of it depends on the comfort level of the patient, the comfort level of the provider who's doing the delivery at the same time. So you want to recognize that that's also a consideration.
Yeah.
But
and what's going on in labor?
In labor too,
sometimes,
right? You can.
Sometimes we just have to make things move quickly.
Right. And for some of our patients, they're squatting. Okay. Some of them are on all fours in terms of delivery process. So
lying on your side, that's a big one.
Yeah, that's actually a great delivery kind of circumstance. And even
still
while you're
safe
pushing.
With an epidural.
Yeah. And so, we're also at the mercy of, do you have an epidural or not?
Right.
Because the epidural takes out the truncal support that you would have. And so you can't necessarily squat. So that epidural is a key factor. Once you get it, you're confined to a certain position during your labor experience. Interventions.
Sometimes those have to
thoughts?
happen.
Yeah.
Sometimes they're those. I think the most important thing about interventions, they're not something that people would ever choose, of course, but sometimes they're important. And I think the question is, do you know what potential interventions exist? And that's important. And then what should happen, and I think what happens most times is that the provider, once they're making that decision that we need to move to an intervention, they'll take just a minute to say, this is what we have to do. This is why we have to do it. But hopefully by that point, you've established a rapport with that provider, and when they're looking at you and they're looking in your eye and saying, we have to do this.
That you trust what
they're saying.
Yeah.
But providers are usually pretty good at that.
That comes back to choosing the one that's right for you, having an understanding of what that means. And interventions really, for us, come in a variety of kind of circumstances for us, okay? There's the aspect of let's expedite this delivery. And with that, there's sometimes what we'll do is called an episiotomy. That's where cutting takes place of the perineum to allow more room to really get this baby out.
Yeah.
There's also vacuum delivery, which is a little suction cup that goes on the baby's head. And everybody's heard about perhaps, forceps, which are like, salad spoons to get the baby out. And then, of course, there's the aspect of the C-section. We're not so much focused on the C-section just for this. Again, we're talking about those other elements there. But episiotomy, and how do you feel about them, Kerry?
Well, nobody wants one. It's usually, and when I talk to patients about them, I say, if somebody's talking about it, usually it's like the baby is right there. You are so close, but we just don't have time to wait. We have to get this baby out. Yeah. And if it's that, or, we put our babies in danger, or, if those are your choices, then of course we do what we have to do. But
yeah. So episiotomies should not be performed because shift change is taking place at 7:00. Okay,
of course,
that's one of those things that it's not done as
often.
Frequent.
No.
It used to be very common, and now it's only reserved if necessary. Because from an evidence standpoint, is that an episiotomy will most likely extend beyond the cutting that has taken place, which can make it problematic, rather than allowing mom's natural forces to create or cause what's a laceration, which is what the baby does, as opposed to the cutting of what the physician will do for you or the midwife. Okay. And so,
and I was going to say, the vacuum I think is definitely more of a go-to than the forceps. Yeah. Very rarely see those anymore. Yeah. But the vacuum is a little bit nice if it's needed. If, you're right there, mom is so close, all it's going to allow is for the provider to help you get that last little bit.
Yes.
You're still going to be working. You're still going to be pushing. You're still going to have that really empowering vaginal delivery. You've just got somebody else who's just giving you a little bit more oomph.
Yeah. So it's these again are terminal things at the very end to expedite delivery prospects for you. Now, all of these things should be done with some level of explanation, empowering the patient with the choice to make that decision or not. Right. And The common one that we get is, what about cord blood banking?
Oh,
Okay.
that is a tough one, right? I don't know. It comes up more and more, but then people usually get the bill and they think, no, thank you.
Maybe not.
It's got a lot of promise to it, but I don't know that I've seen a lot of people using it. Have you?
On occasion.
Yeah.
There's really two types.
Yeah.
There's what's considered to be public cord banking.
Right, which is much more affordable.
Which is, yes, and actually has no cost
Usually
to the patient.
free.
Yeah, no cost. But when it's public, it becomes a public specimen as well, so used for anybody in that regard. The secondary aspect is private, and obviously that's the one that incurs all the costs that's associated with it.
But what is it? The people throw it around a lot, but why are we doing it?
Yeah, the cord blood is very, very rich in stem cells. And the stem cells are the beginner cells that you can shape and mold into just about anything.
Any other type of cell.
That's right. And so it becomes important for patients. Let's say, for example, you had a child and that child developed leukemia as a youth. Stem cell and cord blood banking can be very helpful in that regard for that particular family.
Right.
And so a lot of, patients consider it for those particular reasons.
But if that's something that you're going to do, especially with a private, those are things that are all arranged far ahead of going into labor in the hospital. And so depending on which group you work with, they'll tell you exactly what you need to do. Yeah. And the hospitals are familiar with all of these groups. So when you go in and tell them who you're working with, they can usually do what needs to be done.
Yeah, it's not a final hour thing.
No.
Well,
the public one can be.
Well, the public one, yes.
Yeah, the public one, they will ask you usually during labor if that's something that you're interested in. So that is something you could do at the last minute.
All right. The last thing that we're going to touch on is the aspect of delayed cord clamping.
The after part. So you've had this baby.
Yeah, the baby's done.
And usually, assuming everything goes well, most people will have the baby put on their belly directly. And usually at that point, the cord is still attached and the placenta still has not been delivered. So the baby's kind of right here and we're just waiting for that placenta to come. And yes, then we make a decision about the cord.
Yeah.
Delayed cord clamping is a big thing. People talk about it all the time, but I've found that most people don't actually know what it is.
Yeah. And so what does that mean then, Kerry? We're delaying the cord clamp.
I mean, once upon a time when we delivered babies, we just cut the cord.
Yeah.
Right? Like just done. But now we actually leave the baby attached to the cord while we deliver the placenta. Sometimes not that long, but it allows all the blood that's in the cord to go into the baby. It gives the baby just a last little boost of some extra cells and some extra nutrients from mom.
Yeah, I think it's actually standard of care now. Most providers are encouraging the cord and the delayed cord clamping that you would actually have, because it does for a variety of reasons, but it does continue that blood flow to the baby. Now, some patients want to continue it forever. And, I was going to say,
it's standard of care, but it's very different from provider to provider, what that means. Yeah.
And so ultimately, I think you receive a benefit and the significant benefit until the cord stops pulsing.
Yeah.
Which
can be a
fair amount of time. Yeah. And the cord is still going and placenta is still attached, still working. Yeah. So once the cord is no longer pulsing, the likelihood of a benefit after that is very small. So I think it's certainly reasonable to delay the cord clamp until that point in time. Yeah. Now, there are some point in times where this baby needs to, we need to assess the baby and it's not an option.
But like the interventions we talked about earlier, that's something that your provider is going to say, we just can't. We have to take this baby right now. And your provider will talk to you quickly. Yeah. But by that time, you've definitely established rapport with this provider.
Yeah, it's good. The baby's out now.
Because you just had a baby together.
The baby's out now. So with that in mind, there's so much more that we can go over. So much to the point that we're actually developing our own customizable birth plans for both mom and dad.
Yeah.
Ooh, yeah. So that's to come. That'll be available for all eyes to see.
Maybe we should do another one that's just about the dad birth plan. I kind of like the dad birth plan.
That
Right?
I think that one actually is great. We should do it. Yeah, let's do that.
Let's do
How
it.
about that? Okay. All right.
We have the authority.
That's right.
Thank you for joining us on this episode of Stirrups. Be sure to send us your women's health questions and topics you'd like to cover by visiting our website, CarolinaEliteWomen.com. If you enjoyed today's episode, please subscribe to the podcast and spread the word by sharing it. To find out more information about Carolina Elite Women's Care, visit CarolinaEliteWomen.com. This podcast is edited and produced by Earfluence. Stay healthy and stay empowered. We'll talk to you soon on Stirrups.